medical cost control. My name is Dr. Harshman, and I want to teach you about healthcare cost control from the perspective of healthcare insurance, what healthcare is, and an administrative approach, not a clinical approach, to how to control healthcare costs. Why should you listen to me? I have a medical degree. An MBA in Healthcare Administration. And many years experience as a computer programmer. To deal with the healthcare cost crisis, we have to begin at the beginning. What is healthcare? That can be looked at in either of two ways. Health, according to the World Health Organization, is the complete physical, social, and mental well-being of the individual. Healthcare is the process of achieving and maintaining optimum health. That's one way of looking at it, but it's not the only way. This way places a major burden on the healthcare community. Everything that is wrong with an individual's life can be classified as a health deficiency, however far removed from established concepts of health care provision it may be. It includes not only medical care, but also every other consumer good and service. For health care to be cost effective, the scope has to be limited. Let's look at a revised definition. Health is the possession of full physical function, the absence of pain or other subjective manifestation of disease, the absence of threats to health as defined above, and the mental capacity to appraise and optimize one's health as defined above rationally. That is a more restricted definition, and it is something that the healthcare community can work with. Instead of saying, I don't feel good, therefore I am sick, and the healthcare community must do something for me, patients must say, I don't feel physically well, and here is the specific symptom, or I need a preventive checkup to protect myself against this specific threat to my future health. Or say, I don't feel happy, but it isn't because I need medical attention. After all, if you get a craving for a luxury sports car or have an urge to break a law, then the generally accepted practice is to save up for the car or do without, and to restrain yourself from illegal activity even if tempted. The healthcare community cannot be held responsible. My revised definition specifically excludes mental illness if it is not severe enough or if it is not of a kind that interferes with rational judgment. A person can be anxious, angry, depressed, or whatever. Life, unfortunately, contains worrisome, infuriating, and unhappy situations and events. A woman who receives sexual harassment on the job is likely to be angry or depressed. She deserves an improvement in her work environment. But please don't call her mentally ill, counsel her at great length, and force-feed her tranquilizers just because she says she's depressed. The problem exists, and it's important. But that doesn't mean it's a healthcare problem. The World Health Organization definition is from 1948, right after a major war in which many civilians were impoverished or killed, and the undamaged free world looked at the battered survivors with compassion. Bringing or restoring health to them was and is a noble goal. The same holds true for other essentials of life. There appears to have been, unfortunately, some confusion about what were health needs and what were non-health, though genuine, needs. To the extent that the health community has been stuck with the World Health Organization definition, there has been distortion of the role of the healthcare community and even confusion about the definition of health among patients. The extent to which the healthcare community should be responsible for the individual and to which other agencies should be responsible for the individual are both very important political and philosophical questions. They have to be asked, however. We can't just accept the status quo blindly. Healthcare used to be considered, implicitly, the responsibility of the person or family or household with the illness. Someone who got sick was expected to die, remain ill indefinitely, or get better, and there wasn't much that physicians or anyone else could do about it. That was before penicillin, antibiotics, x-ray machines, clean operating rooms, intensive care units, and other important things. The prevailing philosophy was, I am sick, and I have to do everything I can to get better. Those who passively put their faith in other persons' remedies usually lost their money to quacks. Then came scientific advances. Healthcare changed, however, with modern scientific advances and the ability of reputable practitioners to offer effective treatments. Society's model gradually shifted to, I am sick, someone else has the responsibility. Nowadays, one even has insurance with which to pay physicians. One can even say, I am sick. Someone else has the responsibility and I don't even have to pay. Many people consider that the ideal model for healthcare insurance, and I sure wish it would work that way. Unfortunately, it doesn't. An important issue today is the decline of status of physicians. Formerly, physicians could be perceived as like God, someone with life or death power. A physician was a role model. He would treat people without regard to their ability to pay, would work hard, and would not necessarily have very much money, because patients could not necessarily be able to pay, and there was no such thing as insurance. People went into medical practice because they were interested in medicine and because they wanted to help others. That is no longer necessarily the case. Let's look at the reasons why the status of physicians have declined. First of all, scientific community and available publications and media give patients alternative sources of information so that physicians are not the only source. You are watching television. You are learning about medical practice. It is also possible to read about it in magazines or newspapers. Physicians no longer are the only source. You don't have to ask your doctor. You can go to a library or a bookstore and read a medical textbook or a book written in less technical language. Second, technology, not physicians, is increasingly seen as the most important component of healthcare. Perhaps because medical centers and physician group practices often try to outbrag each other about available equipment, old-fashioned brain power, skill, and compassion are underemphasized. It used to be that physicians were considered most important, and then there were penicillin, x-ray machines, and other important developments, and the physician appraised their appropriateness and remained the key component in providing health care. Nowadays, there are hospitals and medical centers with much more elaborate and diverse equipment than most physicians could ever hope to understand. Trust me, I'm one of them. Perhaps because medical centers and group practices often try to outdo each other with publicly announced equipment, ordinary people will say, this group practice or that hospital is better. It has a magnetic resonance imager. That group practice has a CT scanner. This hospital has a cardiac transplant unit, and so on. That's how many uninformed patients decide which doctor or hospital is better. Do you really think that just because one hospital has a magnetic resonance imager and another hospital does not, that the first hospital is automatically better? Not necessarily, unless you have a condition that is likely to need that particular piece of equipment. If the first hospital has one and the second one doesn't, then my first reaction is the second hospital is likely to be cheaper, not the first one is better. Hospitals use complicated accounting methods to convince insurance companies to pay them a certain amount per day or per diagnosis. If a hospital buys an expensive device, then its cost is allocated in various ways so that every patient's overhead goes up. If the hospital bought a billboard or a TV advertising contract, then everyone would know that the money was not spent on patient care and would complain like crazy. But if a multi-million-dollar device is used less than half its capacity at one hospital, and another hospital nearby wants to look impressive, then the second hospital is likely to try to get another device instead of an extra ambulance to shuttle patients back and forth. New York State now requires special permission to purchase many expensive medical devices. What New York State really needs is citizens who will say, you're in charge of the hospital. Spend the money as you wish. But if you're too expensive, we will go elsewhere. And we certainly will not accept accounting practices that make us pay because you have unnecessary equipment. The third reason is the rise of non-physician healthcare providers. Optometrists, podiatrists, chiropractors, nurses, they deliver healthcare also, and they often do it either more competently or more compassionately than physicians, or both. So if you see an optometrist giving an eye exam and you see a physician giving an eye exam, who does the better job? And who does a less expensive job? And who does a friendlier job? It depends on the particular two providers, and it can be hard to tell. The fourth reason is that the rise of women's status and rights has spilled over into the traditional role of women in healthcare delivery. Women now enter medical school and become physicians. But even for those women who follow the traditional female career path and become nurses, they encounter a different role from previous generations. They get more respect than formerly, and part of this reason, the reason for this respect, is that they no longer blindly follow physician orders about taking temperatures, checking blood pressures, etc. They are also perceived as having knowledge. They, for example, are more likely than physicians to know if two substances can be mixed in the same intravenous solution. Such knowledge does not make physicians look worse, but it does make nurses look better. And I think that's exactly as it should be. Nurses work hard too. The fifth reason is that available information allows patients to become well informed about conditions that they have, possibly even before their physicians. If a physician is asked about such information by a patient, he or she will have to answer, "I don't know," or will have to put up some kind of protest and distract the patient from the question, refusing to answer it directly. But either way, the blind faith in the physician as a well-meaning person who knows everything must end. There's an awful lot of material out there. No physician can learn it all. The sixth reason is that physicians are often rightly accused of placing monetary reward ahead of the benefit of their patients. Physicians are accused of doing expensive procedures on patients with money, more so than on patients without money. Hospitals are accused of transporting unstable patients to other hospitals when the patients have no money or insurance. In fact, the New England Journal of Medicine reported a study a few years ago showing that when surgical reimbursement goes up, so does the amount of surgery performed. The seventh reason is that medical malpractice litigation sometimes, but not always, resulting from genuine physician error, receives great attention. When physicians make mistakes, the first thing their patients sometimes think of is malpractice lawsuits with their big judgments. Medical malpractice has received a lot of attention, and many people consider it something that is an appropriate reaction to improper treatment that causes harm to the patient. Word gets around that that sort of thing takes place and that it works. The eighth reason is the third-party interference problem. Physicians are commonly prevented from practicing as they wish by cost-conscious insurers or, less obviously, by irrational patients. The biggest manifestation of patients not being completely rational is that they do not always follow the physician's instructions. In medical terminology, that is called non-compliance. It used to be assumed that what a physician prescribed, the patient did. The patient paid hard-earned money to get the physician's advice. Anyone who was not going to follow the physician's advice simply didn't consult one. There was no insurance, so there was no third-party interference. Patients nowadays sometimes see a physician without having to pay a significant fee and have no financial motivation to follow the physician's treatment regimen or not see the physician in the first place. And even if the patient and physician agree on the treatment, an insurance reviewer may not. If the patient chooses not to follow the instructions, then the physician will look incompetent. If the insurer refuses to pay for the prescribed treatment, then the patient might side with the physician against the insurer. But the patient will probably get significant medical facts from the insurer that challenge the physician's knowledge and competence, even if the patient remains firmly loyal to the physician. There is a challenge to the physician's authority. The ninth reason is that, aware of the possibility that their physicians are fallible, patients challenge them and sometimes get very unpleasant responses. Such responses are different from the "I don't know" I mentioned earlier. A patient who knows more than a physician about a specific medical problem may get a respectful reply when asking about it. But sometimes the physician dislikes challenges and reacts defensively, ruining the image of physicians as being straightforward and open. The 10th reason is that interest in attending medical school has recently decreased, encumbering the medical community with a permanent decline in average physician aptitude. Immigrant physicians, who obviously do not fit the old-time image of the family physician, may be perceived as inferior however good they are. This reason is really two reasons. Here is the reason that applies to prejudiced people. Immigrant physicians and women do not fit the image of physicians as being white, English-speaking men. People who consider white men superior will infer a decline in the status of physicians. I infer a low status of such people, but that isn't really the issue here. The second reason applies to prejudiced and non-prejudiced people. Because of recent threats to the big income lifestyle of physicians, the number and quality of applicants to medical schools has dropped. People who get into a medical school with a rational admission policy, therefore, are likely to make worse physicians, on average, than physicians in previous decades. Some of the brighter young people who might have decided to become physicians are looking to other careers. Also, when one looks at the technology, patients are being kept alive longer and longer, and it becomes, on average, more and more expensive to do so. Note the cost of life support systems, respirators, intensive care units, and so forth. One could be brutal and refuse to provide such services, saying, "Drop dead." That would be economically feasible, but I don't think it is ethical. The other extreme is to keep everyone alive and worry about paying for it later. Well, now is what used to be later, so we have to worry about it now. If one assumes that everyone has a right to stay alive for as long as he or she wants to, and that everyone wants to stay alive as long as possible, then there's going to be a problem. We'll get to that in a later episode. There have been some alternative approaches to paying for health care. The traditional approach is fee-for-service. You see the physician, and you pay the physician. You pay the fee, and you get the service. Recently, a different form of paying for health care has become popular, HMO, Health Maintenance Organization. It is an organization that gets paid per person or household and supplies health care to all covered persons. It differs from a conventional insurance policy in that it can supply some or all of the health care directly, not merely reimburse for it, and almost always restricts covered services, usually by favoring or mandating its own providers. This means that in HMOs, in general, you cannot choose your physician. You pay a fixed fee, and in exchange you get free medical care or medical care with a low copayment, but the HMO chooses who you can get it from and may restrict the practice patterns of its physicians. A PPO, Preferred Provider Organization, is analogous to a bargaining unit. It is a group of physicians or other providers of medical services that accepts a reduced fee from patients in return for receiving those patients who might otherwise go elsewhere. A physician may wish to join a PPO and get many patients at a discount instead of having no or very few patients. Managed care is the provision of preventive and other health care through a group of coordinators, possibly affiliated with an insurer, instead of through exactly one physician. This kind of care includes case management and includes gatekeeper policies, in which a patient does not get access to a general practice or specialist physician without getting permission first. Managed competition, which sounds like a contradiction, has been recently recommended. It is the structuring of health care reimbursement through competitive negotiating groups of providers bargaining with groups of patients to set coverage terms and premiums. If the negotiations take place in a fair, as opposed to an unfair, bargaining environment, then, theoretically, prices and services would be fairly priced and available to everyone. I consider the ideal form of reimbursement to be a spin-off of managed competition, as I will explain in a later episode. That's all for today. Please join me next week when we investigate Haggle Docs, run by the notorious Biller Killer Mishmash. Haggle Docs is a fictitious but highly successful enterprise that often lowers surgical bills dramatically by merely bargaining directly with the surgeons. I will demonstrate the wrong way to bargain. Biller Killer will demonstrate the right way. To anyone who wants to see a dry and academic discussion of the problem, don't fail to miss next week's show. You heard me right. If you want money-saving ideas based on real-life experience, presented in a more lively way than today, please tune in again. My time has come, and I must fade away. For a free public access program guide of all the shows on public access, send a self-addressed stamped envelope, 2 stamps, a 29 and a 23, that's 52 cents postage, to Access Manhattan Magazine, Department EJH, Box 319, Gracie Station, New York, New York, 10028. Please specify if you want Paragons or Manhattan Cable's schedule. It's free. Do you want to do your own show? If you have an idea for a non-commercial show centered on healthcare cost control, any perspective, any format, and are willing to supply a finished videotape or rent a studio for a live show such as a call-in format, please let me know. 212-865-7552. If you have an idea for a show not related to healthcare cost control, but like another show you see, then maybe its producer would be interested. Call the telephone number displayed during the show and offer your ideas and, very important, labor. It's public access, and you're the public. For a free public access program guide of all the shows on public access, send a self-addressed stamped envelope, 2 stamps, a 29 and a 23, that's 52 cents postage, to Access Manhattan Magazine, Department EJH, Box 319, Gracie Station, New York, New York, 10028. Please specify if you want Paragons or Manhattan Cable's schedule. It's free.